G4-related disease. Thank you so much for taking the time and being here today. My name is Dr. Romy Chamoun. I would like to start by thanking the Pakistan Society for the Study of Liver Diseases, PSSLD, for hosting this webinar. I would like also to thank Professor Zaigham Abbas for this great opportunity. Dr. Zaigham Abbas is the president of Pakistan Society for the Study of Liver Diseases. He is currently working as head of the Department of Gastroenterology at Zaigham University in Pakistan. He is also a member and an ex-dean of the Faculty of Gastroenterology in the College of Physicians and Surgeons in Pakistan. He's the governor of the ACG for Pakistan, and he has represented Pakistan in many international meetings as a faculty member. And he has more than 200 publications to his credit. It's such an honor meeting you, Dr. Zaigham.
Thank you very much. Thank you very much.
In our webinar today, we will discuss the immunoglobulin G4 related disease. As we all know, this is a multi-system immune-mediated disease. It involves multiple organs, where the most commonly affected organs are the pancreas, lacrimal and salivary glands, as well as the kidneys. It is now recognized as the cause of a large number of chronic inflammatory conditions previously thought to be idiopathic. What's challenging about this disease, it leads to the formation of a mass within organs, often misdiagnosed as malignancy. So today in our discussion, we will go through details about it. I would like first to introduce our phenomenal expert team for today. We have a great team of panelists and speakers. I would like to start by introducing Dr. Muhammad Hassan. Dr. Muhammad Hassan is the Director of Advanced Endoscopy Fellowship Program at the Center for Interventional Endoscopy. He has completed his residency and fellowship at the University of Oklahoma. Dr. Hassan went to Mayo Clinic, Jacksonville, and completed a training in EUS and advanced endoscopy. He has authored many professional articles and book chapters, and he has also participated in many national and international conferences. Welcome, Dr. Hassan. Our second speaker, panelist is Dr. John Leeds. Dr. John Leeds is a consultant gastroenterologist and pancreatobiliary physician at the Freeman Hospital in Newcastle upon Tyne. He was initially appointed to Aberdeen Royal Infirmary, where he was a crucial part of the hepatobiliary team and the advanced endoscopy service. He contributes to the area of pancreatobiliary medicine and published a number of papers and reviews in the area. Welcome, Dr. John. Our third panelist is Dr. Dalbi Sandhu. He's the Director of Endoscopy at Cleveland Clinic, Akron General. He's a professor assistant at Case Western Reserve University. He finished his internal medicine from the prestigious Cook County Hospital and his fellowship at the University of Iowa Hospital. He also trained in endoscopic ultrasound. Dr. Sandhu has special interest in early diagnosis and treatment of various gastrointestinal malignancies. For now, I would like to introduce our three amazing speakers. First, we have Dr. Pawlak. She's an MD PhD at the Hospital of the Ministry of the Interior and Administration. We also have Dr. Nadeem Tehami. He's a consultant hepatologist and HBV physician at University Hospital Southampton in England. And Dr. Kesha and Dr. Nadeem both have a clinical interest in hepatopancreatic biliary diseases. Our third speaker is Dr. Tossapol Talks. Dr. Toss is trained advanced endoscopist. He leads the Geisinger Pancreatic Cancer Screening Program using a large-scale MyCode exome sequence and is the co-director of the National Pancreatic Foundation Program. His clinical interest is in EUS, ERCP, and in innovative advanced therapeutic endoscopies. Welcome, our speakers. Our outline for today, we're going to start with a joint presentation led by Dr. Kesha and Dr. Nadeem Tehami. It will be followed by a presentation by Dr. Toss about endoscopic management of autoimmune pancreatitis and cholangiopathy. And as you all know, this is an interactive webinar. So if you have any questions, you can use the Q&A function to submit questions, the chat to submit questions, and I will pass those questions to our panelists and speaker. And you also have posted a link in the chat for everyone to be able to answer questions that we will be posting during our presentation. I will now give the mic to our two presenters, Dr. Kesia and Dr. Tehami.
Romy, thank you very much for the introduction. I'm very grateful to all the panelists, speakers, and PSSLD, including our chair, Professor Zaigham Abbas. Especially I would like to thank Romy because she's post a 28 hours ICU call. So I'm really grateful. And I would start off this talk, which is going to be a double act with myself and Dr. Pawlak. The remit of the talk is we will take you through some case vignettes, an emotional roller coaster. We will touch upon the pathogenesis of IgG4 related disease, and then the main focus of the talk will be on the clues to the etiology and management of the condition. Dr. Pawlak will chip in from time to time, highlighting the recent UEG guidelines. So the first case that I would like to share with you is of a 28-year-old lady who presented back in September 2018 with painful jaundice, a short history of painful jaundice, elevated liver enzymes. She went on to have an ultrasound scan which showed dilated intra and extrahepatic ducts. She had a CT scan which showed this enlarged pancreas, but we could not appreciate rim of hypodensity, which is described in literature as a pointer of the diagnosis. She had some indentation in her renal parenchyma, which is also considered as a pointer toward the diagnosis. When we looked at her blood, she had raised eosinophil counts. We asked for further panels of tests, which showed that her complement levels were decreased. Her IgG4 and CA99 were normal. For some reason, we had not requested IgE levels for this patient. So she went on to have an ERCP. She had this distal biliary stricture. She was stented. We used the shortest available 10 French at the time, which, as you can see, was quite long. She went on to have temporary biopsies and the biopsy of her pancreas, which looked enlarged with normal pancreatic duct, and parenchyma did not look any remarkable. So we got the confirmation of the diagnosis of IgG4-related autoimmune pancreatitis. She was started on steroids. She responded really well. Her symptoms improved. A few weeks later, we went in, we removed the stent, and she seemed to be okay from that point onwards. She wasn't keen on starting any immunosuppression because she was trying to conceive at the time. And the question for the participants is, does she need immunosuppression? So what I would like to do is, if I can ask the participants to go to this website, www.menti.com, and use the code 4850419, and you should be able to choose one of the answers. So she's improved following a course of steroids. She's now without stents, doing well, not keen on immunosuppression. Does she need long-term immunosuppression? I don't seem to be getting any response. So if you are, log on to the website www.menti.com and use the code 4850419.
Maybe we can put on the screen the website.
Just put it in the chat, Nadeem.
That's okay. I think just in the interest of time, we will move on. So this lady wasn't keen on starting immunosuppression. So we did not offer her any immunosuppression. We continued with a close follow-up, and she was last seen in July 2020, and she's been doing really well. So a happy outcome for this young girl. So the case two was of a 68-year-old man who was seen by his GP with a new diagnosis of diabetes mellitus and associated weight loss. He had normal liver function test, but given a concern of the pancreatic cancer, he had a CT scan which showed enlarged pancreas, mostly the tail of the pancreas. And we therefore requested panel of the blood test and noted that he had elevated IgG4 levels, which was 2 times the upper limit of normal, and his IgE level was also raised. We maintained a close follow-up. He had a further CT scan a few months later, which did not show any evidence of malignancy, and his pancreatic changes improved. He was managed for his diabetes, given some nutritional supplements, and continued to do well. I had another question, but again, in the interest of time, I will skip past the question. The question I had at that stage, if he had autoimmune pancreatitis and if he needed treatment. We did not offer him any treatment. And 2 years down the line, he comes back with painless jaundice, elevated bilirubin, and quite least elevated alkaline phosphatase. At this stage, he had a CT scan which showed that he had a thickening of the ducts around hilum, had an ERCP, strictures were brushed. We took some ampullary biopsies, stented him, took some ampullary biopsies, and on the immunohistochemistry, we found that he had evidence of autoimmune IgG4 related disease. This case obviously puzzled us, and the last case that I want to share with you is of a 40-year-old man who was referred with non-specific symptoms of tiredness, lethargy, lassitude. Had panel of blood tests, and they were all normal, including tumor markers, IgG4, complements, and IgE levels. So he went on to have some imaging, which demonstrated that he had these two areas of abnormality or of low density in the tail of the pancreas. He had this retroperitoneal fibrosis with some thickening around his aorta. So we attempted EUS, took some biopsies from these areas, which was not conclusive. He went on to have a biopsy. He had a bit of a goiter as well. So he had an FNA of the goiter that was also not successful or did not give us any diagnosis. Obviously, the concern was because he remained pretty much the same with tiredness and lethargy. He ended up doing a PET scan on this man. And then the PET scan on him showed that he had a lung nodule. He had this retroperitoneal fibrosis around his aorta. He had these two lesions in his tail of the pancreas, which lighted up, and then the thyroid itself. So having not been successful with his tail of the pancreas and thyroid biopsies, he had a lung biopsy, which confirmed the diagnosis of IgG4 related disease. He was again put on steroids and seems to be doing reasonably well. So what I have demonstrated here, that it is a multi-system disease which involves different organs of the body. And hopefully this case would have demonstrated that the value of the PET in such cases, because it helps us in determining the sites of the active disease. Now, it helps us to assess the subclinical organ involvement, helps us in targeting the biopsy, and sometimes assessing the response. However, these findings are not disease specific. We have to consider the radiation dose involved and clinically what is the relevance of the subclinical disease. Now, so there are 4 disease clusters that we're talking about when we talk about IgG4 related disease. It is a multi-system disease, and because it's a heterogeneous disorder, so it differs in age, gender, ethnicity, serum IgG4, and also time to presentation as well. So we will be focusing on the HPB cluster, or I'll be focusing on the HPB cluster of this condition. So if you focus on the graph on the left side of this chart, then what you will see is that these patients in HPB clusters, majority have involvement of the pancreas, biliary, followed by submandibular gland, and also in renal and the lymph nodes involvement. What we conclude at this stage is that it's in this cluster, which is sort of about 25% of the total cohort of these patients. It is a male predominant condition. Time to diagnosis could be up to a year. It could take even longer. And we tend to see elevated serum IgG, which if it is more than 2 times upper limit of normal, it helps in the diagnosis. We will talk about this in a little bit more details later on. Now, for a clinician looking after patients, and when you have, so one, obviously you have to consider this condition. And when you consider this condition, when they're presenting with the HPB symptoms, examination of the neck is helpful. We ask for the CT scan of the whole body to rule out any underlying cancer, which is quite important to exclude. We then ask further investigations, including MRCP and EUS, to define bile and associated pancreatic duct. Now, my colleague is going to talk about EUS, so I'm just going to not mention much, but we tend to go for FNB rather than doing an FNA. And there has been some question raised by colleagues in terms of biopsying a pancreas, inducing a pancreatitis if it isn't there, but we haven't seen any increased complications in our practice. So in this cluster, obviously, it's important to talk about the autoimmune pancreatitis, which presents with weight loss, symptoms of fat malabsorption, obstructive jaundice, and abdominal pain. The test that we usually ask for is fecal elastase, HbA1c amylase. We tend to see low level of complement, C3, C4, and elevated IgG4. And when you do a ratio, that helps you in reaching to a diagnosis. Serum IgG level seems to be raised, and eosinophilia in the full blood count is sometimes helpful in getting the diagnosis. So 2 types of autoimmune pancreatitis. Common is type 1, type 2 is rare. We usually decide this based on the histology. Mean age in type 1 common condition is usually in the 6th to 7th decade, whereas type 2 is mostly seen in the young patients. Presentation is this jaundice and acute pancreatitis in both. Now, other organs involvement is usually common in type 1 autoimmune pancreatitis, and serum IgG4 level are elevated in type 1 and not so in type 2. We tend to see involvement of or presentation with inflammatory bowel disease in some patients with type 2, and type 2 does not seem to have a lot of relapse or recurrence, as possibly we've seen in the first case that we presented. Now, one of the take-home messages from this slide is that although in type 1 you see elevated serum IgGe, but up to 30% of the patient have normal IgG4 levels. So now I'll hand over the mic to Dr. Pawlak to just take us through the guidelines.
Thank you, Nadeem, for this great case presentation. And now I would like to just add a couple of words according to our current UEG guidelines. So when we are thinking about the diagnosis of IgG4-related disease, we should know that diagnosis should be complex. And here we know that assessment of histological samples is very important for us. So we should check this, and we should start with taking a biopsies from these patients. Also, we should look at imaging examinations and some abnormalities in imaging examinations. And also in these imaging examinations, we should check the other organ involvement, which is extremely high and which is extremely frequent in IgG4-related disease. Also, in some cases, serology tests can be very helpful to estimate diagnosis, but also for us as a clinicians, the assessment to response to glucocorticoid therapy can be crucial for the making the diagnosis. Next. And when we are thinking about the IgG4-related disease of the pancreas, we are thinking mostly about the HAP type 1. And here the current guidelines highlight that we should look for some imaging features of HAP. And here we can see that we can check the parenchymal changes suggestive of HAP. Like, for example, for the HAP type 1, we should look for diffuse enlargement with the loss of the normal multilobulated pattern. However, in HAP type 1, we can see that changes can be focal. Also, we can see that changes can be very different. Back, please, the earlier slide. And we can see that we can have the cat-tail sign and also the other changes in the parenchymal suggestive for HAP. Next. And besides the parenchymal changes, we should look for the ductal changes suggestive for HAP, like we can have the different changes with the long segment or even multifocal main pancreatic duct involvement with narrowing and also vanishing this duct. Also, we can see the skip lesions, and in some cases, we can observe the duct penetrating and also icicle signs in characteristic for HAP type 1. Next. And besides the imaging examination changes, we should look for the pathological characteristics of HAP type 1. And here is extremely important to estimate and to differentiate HAP type 1 from HAP type 2. And also current guidelines highlight that we should look for the 4-path elements characteristic for HAP type 1. And what can be different from HAP type 2 than that for HAP type 1, we can observe IgG4 positive plasma cell infiltration, which can be scant or even absent in HAP type 2. And when we have isolated IgG positive plasma cell in our histological results, we should know that this is not enough for making the diagnosis. So here can be very helpful IgG4 IgG ratio, which should be higher than 40%. But also current guidelines highlight that surgical and biopsy samples are different when it comes to the number of cells. So in surgical samples, we will have higher number of cells just in case biopsy samples. And for us, as an endoscopist, it's very important to estimate and differentiate the IgG4-related disease of the pancreas from the pancreatic cancer. And here we have the role of endoscopic ultrasound, and also current guidelines highlight that the endoscopic ultrasound plays the major role in the diagnosis of IgG-related disease of the pancreas, but also in the IgG4-related disease of the hepatobiliary tract. And here it's not about only pancreatic imagination findings, because sometimes it's extremely difficult to see and to differentiate it even from pancreatic cancer when we have the tumor. But very important for us is to obtain the tissue samples for histological diagnosis. So current guidelines recommend that 19-gauge needle can be used for a core biopsy, but also 22-gauge needle for histological evaluation can be allowed. Next. And we can ask also about the role of surgery in HAP type 1. About 7% of HAP type 1 can have concomitant benign and malignant lesion. And based on current studies, when all resected suspicion of cancer, up to 30% of changes was benign, and also up to 43% of changes were related to HAP type 1. We should also know that differences in reported recurrence rate after surgery was up to 41%, so it's extremely high. But in cases when we have patients who undergone pancreatectomy for HAP type 1, we should see that these patients need a careful long-term follow-up for this group of patients. Next. So our guidelines indicate that surgery is generally not indicated for HAP type 1, but might be considered in cases when we suspect of pancreatic cancer, and this suspicion cannot be excluded after complete the diagnostic workup. Next. So I would like to just mention a couple of words generally about HAP type 1, what we should look for during the diagnosis and during the management with these patients. So HAP type 1 is a special and treatable form of chronic pancreatitis with a good response to glucocorticoid therapy. However, it's related to high rates of disease relapse, even up to 55%. So we know that very common is other organ involvement, but when we are carrying these patients, when we are treating patients with HAP1, we should know that the treatment is very special and we should look at the exocrine and also endocrine insufficiency. Next. So from our guidelines, we see that screening for a deficiency should be considered, and also for patients with HAP type 1, lifelong follow-up is advisable. Thank you.
Okay, so we're going to talk briefly about the two other presentations. One of them is a sclerosing cholangitis, which again presents similarly with obstructive jaundice weight loss. Cholangitis is usually rare. They have cholestatic pattern of liver function test and have slightly elevated inflammatory markers. 4 different types. Important to exclude the differential diagnosis to exclude is of pancreatic cancer, cholangiocarcinoma, and also primary sclerosing cholangitis, which can be very difficult to diagnose. So there is a role of EUS, FNA, cholangioscopy, introductory ultrasound scan, which will be touched upon by one of my colleagues a little later. Now, we regard PSC in hepatology world as a black box of hepatology, incredibly difficult disease to diagnose. And if we then have a differential of a condition like sclerosing cholangitis with IgG4, it becomes even more difficult. But there are some pointers. For example, on MRCP, you would see typical beaded appearance, which is seen with the PSC, whereas with the IAC, you will see fleeting and migrating biliary strictures. His tissue is always an issue because that would give you the diagnosis with fibrosis of typical onion skinning with a PSC, whereas with the IgG4 related disease, the criteria includes storiform fibrosis, obliterative phlebitis, and a ratio of IgG4 over IgG of more than 40%. There is association with PSC of autoimmune disease. We tend to see that also with IAC, which does make it quite difficult to differentiate. With IBD, we all know there's an association with the PSC. We tend to see that in type 2 autoimmune pancreatitis as well, but not in the sclerosing cholangitis associated with IgG4 related disease. And it's important to exclude cancer with patient with the PSC. Once we have excluded that in patient with IgG4 related disease, that is not usually a concern. Ursodeoxycholic acid is not a treatment, is not an evidence-based approach for PSC. However, patients with PSC tend to show response in terms of improvement in their liver biochemistry, which is not seen in patients with IAC. So it is not straightforward. However, you have to keep these differential in mind. I've come across cases where people have asked about IgG4 related hepatopathy. Now, one of the key take-home messages from today's talk is that liver is concurrently affected in autoimmune pancreatitis, not in PSC, not in IgG4 related sclerosing cholangitis. So if you are considering IgG4 related hepatopathy, consider or rule out underlying autoimmune pancreatitis. Some patients, there are some case reports, which is what I've shared here, who would have had presented with these inflammatory pseudotumors, which could look like a cancer on imaging. But what you see on this histology slide here is that there's an abundant lymphoplasmacytic reaction, and on immunostaining, you'd see IgG4 infiltrating the tissue. Therefore, you have to question twice if you are diagnosing a patient with IgG4-related autoimmune hepatitis. Over to you, Kasia.
Oh, thank you. So here from the current guidelines, we see that the most common manifestation of IgG-related hepatobiliary disease is IgG4-related cholangitis, and mostly manifests as a glucocorticoid-responsive cholangitis with involvement of different segments of biliary tract. But sometimes, as you mentioned, Nadeem, can be visible as inflammatory pseudotumors of the liver, but in some late stage of the disease, we can observe also biliary cirrhosis. And up to 75% of patients is related with the other organ involvement. So also here we can observe the HAP involvement and HAP disease. Next. And the diagnosis, as I mentioned before, should be complex for IgG4-related hepatobiliary disease and should include the clinical, biochemical, pathological, and also radiological characteristics. But sometimes it's extremely difficult to differentiate the pancreatic tumor like adenocarcinoma from IgG4-related disease. And also here in case of hepatobiliary disease, and when we have the patients with painless Jordans, we have to know that it can be also a carcinoma. So very helpful here can be estimation and assessment of cholestatic serum enzyme profile, as also we can check the elevated serum IgG concentrations. And the main key can be here histological assessment, as well as the checking the imaging examination with extrahepatic or even hilar and intrahepatic bile duct strictures visible. Next. And what we should know from the biochemical test and what we should remember during the steps of the diagnosis, that CA99 can be excessively high in IRC and responds rapidly to glucocorticoid treatment. When it comes to IgG4, up to 75% of patients can have elevated level of IgG4. However, for the diagnosis, we can make the diagnosis when IgG level is higher than 4 times upper limit of norm. And in 10% of patients, we can also observe the moderate elevation, and it can be characteristic for patients with PSC, with cholangiocarcinoma, also with pancreatitis, and even with pancreatic carcinoma. And helpful can be here also the blood IgG4-Ig RNA ratio with excellent accuracy for the diagnosis. But when we have the patients without current histology, sometimes can be very, very difficult to assess the patient, and especially when the patient is ongoing steroid therapy, then the IgG4 level can be in norm. So here, in this case, IgG subclass 2 may help in the diagnosis of IRC. Next. And also from current guidelines, we can say that if it's the treatment response, very important for us as a clinician. So here we know that the treatment response is regarded as a major diagnostic criterion. However, in this case, it's not indispensable for the diagnosis of IgG-related cholangitis. Next. And when it comes to IgG-related disease of esophagus, stomach, and bowel, we know that typical clinical features are rare, and we should look also for esophageal strictures, for some gastric ulcers, also even colon polyps and fibrous masses. However, histological criteria can be crucial for the diagnosis, also helpful with the biochemical tests. However, what to do with the patient when we can see in imaging examinations gastrointestinal mass lesion, when we do a couple of samples of biopsies with non-diagnostic histology, and also we can see the malignant cells in our samples. So the current guidelines say that empirical treatment with glucocorticoid for 1 month can be a suitable option for this group of patients. And then we can see in imaging examination, also in clinical tests and biochemical tests, if this therapy make any result. Next.
Okay, so I know we are sort of running a little behind on the time, so we've only got sort of about 5 more minutes to finish this before Toss takes over. So we've spent a lot of time making sure that we get the diagnosis right, and that is quite important. There are different criteria available, and the international consensus criteria for the diagnosis is something which is commonly used world over, which has obviously histology as a cornerstone for the diagnosis. You're relying on the biochemistry and clinical presentation. Now, in clinical practice, I tend to use high sort Mayo Clinic criteria, which is H for is histology, I for imaging. You've got S for serology, O is for the other organs involvement, and RT is for the response to treatment, which is what we tend to use in our clinical practice. So primary aim is to exclude the alternate diagnosis, where the secondary aim is to confirm the diagnosis. Now, very quickly about IgG4, as Kashi already mentioned, that you will see 10% of the patient with cancer who will have a elevated IgG4 level, which is why therefore we should not overemphasize on isolated rise in the IgG4. Moving on to the treatment. So treatment aim, as we've discussed, so we would like to induce the treatment, which is mostly with steroids, and then we talk about the maintenance and the treatment of the relapse. So over to Kasia. Kasia, we've got 5 minutes.
Okay, so very shortly about the treatment. So we know exactly that all symptomatic patients should be treated. However, what to do with asymptomatic? So in current guidelines highlighted that patients with pancreatic masses in imaging examinations, also with persistence cholestasis in bile tests, and also with subclinical situations that could lead to severe organ failure, we should treat also this group of patients. And there is also no relevant data which support the treatment for only for just to limitation the risk of pancreas insufficiencies. Thank you. Next. And the first line of treatment are glucocorticoids, and here you can see the typical doses which can be used for treatment of IgG4-related disease. And after inducing the remission, we should start thinking about the gradually tapering of glucocorticoid. And what is the most important here, that we should think about the adequate time of the treatment, because the lower doses or even shorter duration time of the treatment can increase the relapse time. And also during the assessment of response, we should look for the clinical, biochemical, and also radiological tests. Next.
So it's really important to identify that 50% of patients or 60% could relapse with these conditions. And when it happens, we have to use the same diagnostic criteria to come to the diagnosis. What helps you in predicting that relapse? So in studies, the consistently associated, so people who have type 1 over type 2, or if they've got proximal biliary disease, those are the two key factors which are consistently associated with increased risks. There are some other pointers which could also help in predicting the disease relapse. Kasia, over to you.
Okay, so when we should start with immunosuppressive agents, and also current guidelines highlighted a couple of clinical situations for the treatment, and we should think about the immunosuppressive agents when we have the multi-organ involvement, also the patients with the high risk of disease relapse, also when we can see the relapse after maintenance of the remission strategy, and with the patients when the disease of active disease and even disease relapse during the 3 months of treatment, then we should think about the immunosuppressive agents. Next. And also here are the definitions for the immunosuppressive agents, the definition of remission and also of relapse. But what is important and what we should remember, that we should assess the long-term side effects of glucocorticoid therapy. And then we should look for the role of immunosuppressive agents. Next. And the last couple of words about the immunosuppressive agents, that the second line of treatment is rituximab, and it should be considered as a treatment. And when we have the resistant or even intolerant to high-dose glucocorticoids, and when we have failed to respond to immunosuppressive therapies. Also, we can see the different agents like thiopurines and the different like methotrexates and even mecophenolate mofetil. However, there is no a lot of data about the treatment, so the second line should be rituximab.
Okay, so I'm not going to bore you with lots of studies, but essentially your maintenance options are either low-dose steroids or immunomodulators. Now, this study did support using long-term steroids. However, this was an underpowered study and it was closed due to slow recruitment. The options of thiopurines, we have got no randomized controlled trials to support that. And in our experience, we have not found major success using this alone or with steroids. So there are trials in favor of using mycophenolate or cyclophosphamide in combination with steroids, which have proven the reduced relapse rate with using these agents with steroids. But with the mycophenolate, there wasn't significant toxicity. However, with cyclophosphamide, significant toxicity was observed. Kashi has mentioned about rituximab already. Therefore, the treatment for the relapse is to confirm the diagnosis, consider either rituximab as an induction and go straight for the rituximab maintenance, or start with steroids and then consider the immunomodulators. So there are some knowledge gaps, and going forward, we would like to improve the biomarkers for the diagnosis and subtype of classification. And we would really like to be able to consistently obtain the tissue for the diagnosis, and work really needed to do some clinical trials to guide the therapeutic decisions. Kashia, please excuse me, I will skip past your take-home message slide and just mention one last slide for the next 30 seconds as to how to get it wrong if we keep considering other diagnoses and not considering this diagnosis, and if we keep overemphasizing the serum IgG4 levels. We must not work in specialty silos, especially when we are dealing with a disease as complex as IgG4 related disease. So thank you very much there. I'll pass on the mic to our moderator and apologize for taking a little longer than planned.
Thank you so much. It was a very interesting and interactive presentation. I would like now to hand the mic to Dr. Toss.
Yes, sure. Hi, everyone. My name is Toss. First of all, I would like to thank the whole panels and also Dr. Abbas for this invitation. So today I am assigned to talk about the endoscopic management of the autoimmune pancreatitis and cholangiopathy. And it seems like the panelists already covered lots of aspects about the things that I might want to talk earlier. So I will skip real quick. So only two agendas today. So when we talk about the endoscopy, we talk about diagnosis. I think we play a major role. For the treatment, in my opinion, at this time, I think that we played a very minor role here. So again, to diagnose the AIP, tissue is the issue. So initially, you have to think about the histology, imaging, serology, other organ involvement, and response to steroid therapy. And then there is another separate criteria that we use nowadays. It's called ICDC. And there are a lot of confusions of terminology. So for this presentation, I'm going to call AIP type 1, that the ICDC now, they change to only the term AIP. And then for the AIP type 2, they rename it to idiopathic duct-centric pancreatitis. The only difference is that for the AIP type 1, you must see lymphoplasmacytic sclerosing pancreatitis. And if you're lucky, then you see a lot of IgG4 cells. Then the IDCP, or the type 2, is completely different. You see the granulocytic epithelial lesion and very minimal IgG4. So it's like pretty much not quite the same. This is a quick update from the ICDC. So you can see in the highlight that I put here in the section of the other organs involvement, they classify into level 1 and level 2. Level 1 has a strict criteria. You have to have like lymphoplasmacytic infiltration. You have to get a storiform fibrosis, obliterative phlebitis, and a lot of IgG4 cells. For the pancreas, they make another separate sessions, and then you can see that how strict they made the criteria. There are 4 criteria. You have to meet 3 to be called level 1 evidence. And you have to meet at least 2 criteria in the pancreas pathology to call level 2 evidence. So, and this is the criteria for the idiopathic duct-centric pancreatitis. So basically, you don't need the IgG4 to diagnose that. So what do they mean? This is a slide from the Mayo Clinic by Dr. Suresh Shari group. The left upper, you can see a lot of plasma cells attacking the pancreatic duct. And then B and C, you can see a lot of storiform fibrosis. It described as like a whirlpool appearance of fibrosis, and a lot of inflammation at the venous system, but very sparing. It spares the arterial system. And obviously the image D is about the ITT4. So another nice image from upper row to lower row. This one, the left upper is a lymphoplasmacytic infiltration, the low magnification, high magnification. And then figure C, you can see like it looks like a whirlpool of like a fibrosis. Figure D is the venous is gone because the inflammation is there, while the artery is like still spared. ITT4 is fine in the figure E. And then the last figure here is a type 2 AIP. So it's a lot of neutrophils and then a lot of granulocytic epithelial lesion. So tissue is the issue. So what we know about how can the endoscopic procedures help? So we start with a fine needle aspiration back in 2012. At that time, they collected the data from the Japanese hospitals. They used a 19 gauge. And what they found is that out of 44 patients, they can identify adequate cells up to 41 patients with a very minimal adverse event, only one patient with abdominal pain. And you can see here that the initial study shows very promising data. 43% you can diagnose AIP right away. So this is a picture that they got from the 19 gauge fine needle aspiration, very typical pictures of the pathology. Then another study, they consider that 19 gauge might be more harmful because you put the needle into the pancreas. So they use a smaller needle, 22 gauge. This time they use two types of needles, but the main one is the one that I attached here. So what they found at that time is it's still helpful for the fine needle aspiration. And then this time they use a very strict ICDC criteria. And they use two pathologists to perform the inter-observer analysis to see if it's agreeable among the two pathologists. Again, they have a very nice samples shown here, and everything is correlating with what we would call AIP nowadays. And what the two pathologists are less concordant in terms of like their agreement is the obliterative phlebitis. But the rest of the criteria, they agree very well based on this needle. So it's not until about 4 years after that, that's how the first prospective studies performed throughout the Japan, 18 hospitals, and then they include about 50 patients into the study. The very interesting finding here is that the fine needle aspiration that we thought is good, it is actually not good. The sensitivity is only 8%, specificity is 100%. Positive predictive value is 100%, negative predictive value is 26%. What does it mean? It means that if you find a very typical AIP, it helps. But if you don't find, it doesn't help. Then they further the analysis with the level 2. If you recall the initial slides when I said that the level 2 require less criteria. They said that even if we put some less criteria on it, we can still cannot diagnose the AIP with the fine needle aspiration. And this is a diagram that they try to show that it doesn't help much using the needle aspiration. So about a year after that, our group from the University of Michigan, we have a case that we use a new needle, which is a fork tip on the right side. And then we can demonstrate that you can see a very nicely identified storiform fibrosis around here, like a whirlpool. You see the normal pancreatic parenchyma, and then you see a lot of lymphoplasmacytic infiltration. And when you stain the ITT4, you see a lot too. So maybe the fine needle biopsy rather than fine needle aspiration could be the answer. So this is a very good study that was published this year. It is another multi-center randomized control trial. They randomized between the 22 gauge Francine type or 20 gauge forward bevel type. And then this time, again, they use a strict ICDC criteria, and they just want to find the sensitivity of between the two needles. So the first one is a Francine, is a fork tip. And then the second one is the bevel. So basically when you puncture to the pancreas or any tissue, when you withdraw, that's how you get the tissue back into your needle. So you can see that this is a very impressive amount of tissue that they got from either needles. Then again, they demonstrate that with this type of fine needle biopsy, they can demonstrate anything that the ICDC would require for the diagnosis. Then it is a randomized trial, and then they want to see the sensitivity, and they can prove that the fancy needle here is actually outperform the forward bevel needle in both of the level 1 and level 2. So now we know that maybe the fancy needle might be the answer, might be the best type of approach. What else that the endoscopy can help you? So I'm going back to the approach of the AIP based on the ICDC criteria, and I just highlight the topic that they want us to address. One is the endoscopic pancreatogram. So basically you have to perform ERCP. You inject the contrast into the pancreas, so you try to see the stricture. Personally, my approach, I do not perform pancreatogram just to document that this is AIP, because we have like very good alternative. MRCP and MR pancreas nowadays is like almost at the level of ERCP. And I don't want to take risk of post-ERCP pancreatitis just to diagnose a person. There is a comment about ampullary biopsies. This one, I do it very often if I suspect, but you have to be very cautious not to perform the biopsy that can cause the injury to the biliary or the pancreatic orifices. And we pretty much talk about the pancreatic core biopsy. This is the approach again for if you think about the type 2, then they suggest that you could consider pancreatogram, but again, I personally do not perform that. So those are about the diagnosis that I think we played a major role in the diagnosis. What about the treatment? So mainly is for the biliary stricture, and then as many people have mentioned, the AIP and IgG4 sclerosing cholangitis could look the same. It's the same entity, but if you have IgG4 sclerosing cholangitis without anything else, without autoimmune pancreatitis, without any other organ involvement, think twice, because most likely it will be some sort of cancer. And the biliary stricture is very different from pancreatitis. Pancreatitis, if you start steroid, within a few weeks, it will resolve, the sausage pancreas will be gone. Almost universal improvement, almost 100%. Biliary stricture is different. It has a variable response, and it takes up to 5 months. Has a very high relapse rates. So it's not very high efficient treatment with the steroid. That's why sometimes you have to even start with a stronger medication such as rituximab when they have the proximal biliary stricture. Then there are a lot of terminology that Nadeem already talked. And then I would like to highlight here that for the term that you should use currently is IgG4 sclerosing cholangitis. And then the other part that I want to emphasize is that IgG4 related autoimmune hepatitis is the autoimmune hepatitis that you can stain IgG4 cells. This is not in the criteria for IgG4 related disease. And then the last one is an inflammatory pseudotumor. If you can fulfill the whole criteria for histopathology, you can call that, it could be one of the features of the IgG4 related disease. The most common features that you're gonna see in the biliary stricture from the autoimmune pancreatitis or from the IgG4 is the distal biliary stricture. Keep in mind that the pancreatic cancer of the pancreatic head will look the same. And once the stricture moves up into the liver, you have to think about PSC, you have to think about cholangiocarcinoma rather than just the IgG4 alone. And then this is again the study from the Mayo Rochester group. They try to prove that the IgG4 level is actually doesn't help you much comparing cholangiocarcinoma and IgG4 sclerosing disease. You can see the distribution looks the same. They quote that if you use a cutoff of 4 times, sometimes it could be quite specific for IgG4 sclerosing cholangitis. So it can help, but not much. So this is another case that I want to put as a caution. This is a patient that we found to have most likely IgG4 sclerosing cholangitis based on the MRI, based on the ERCP. So we put the stent in. The figure D, we even biopsy the ampulla, and then I can convince you that it's a lot of IgG4 cells. But within 10 days, the patient came back with new onset gastric outlet obstruction, and this is the answer. Actually, the patient has thickness cell adenocarcinoma. It's not a mass-like lesion. It's just found on the surface, and then the ultrasound just look a little bit thickened. So a lot of malignancy can fool you for the IgG4 sclerosing cholangitis. What else we can use in terms of endoscopy to diagnose the IgG4 sclerosing cholangitis? We don't have much data. What we know is intraductal ultrasound might help. Basically, if you see a very thick, smooth wall, homogeneous like this, it can help you to describe as IgG4 sclerosing cholangitis. And the wall can be thickened up to 2 millimeters. Again, it's very hard to diagnose a person with autoimmune cholangitis just based on the ultrasound. Then the subsequent study, they used the cholangioscopy. This is done in 2013. So it's like one of the very first version of the cholangioscopy. They said that if you see a dilated bile duct, the dilated vessels, very tortuous like this, then it could be very suggestive. And this is a picture after the 2 weeks of steroid, complete resolution. So this is a picture from them. I want to guess ask the audience first. When they saw this, I cannot distinguish which one is which. But what they claim is that on the left side, if you see dilated tortuous blood vessel, most likely IgG4 sclerosing disease. This picture on the second row, if you see pseudo-diverticular in the bile duct, maybe PSC. The next one, you see a little bit infiltration, a little bit dilated blood vessel. This is quite typical for cholangiocarcinoma in the distal bile duct. And then the last one is from the hilar region. If you don't see blood vessels, but very much infiltrating area or disease, this is hilar cholangiocarcinoma. I think it is very soft call because if they don't put the description on it, I cannot guess which one is which to start with. Then what about the last question, biliary stenting, would it help? So we know that the main treatment is the steroids. So this is the study from Japan as well. They include overall 59 patients into their analysis. The patients has been treated with biliary stenting with or without steroids at various points. And then I will show you later, like what is the point they start. So they want to prove that you see the distal biliary stricture. You see a very typical pancreatogram like this. You see a very thickened wall, homogeneous wall thickening of the bile duct. So now you are convinced that this is IgG4 sclerosing cholangitis. They're stented, they start steroid, and then it's complete resolution. So this is typical pictures. But the problem of this study is that they don't have a protocolized the biliary stenting or the steroid, which one comes first and at what time. But what they conclude is that once you put the stent in, as long as the patient has a steroid as a treatment, within 1 month after the steroid initiation, you could safely remove the bile duct stent. So what they conclude is that you must use the steroid at the same time or concurrently with the steroid, and the resolution could be quick to the point that you can remove the stent within 1 month. So the summary, tissue is the issue. Histopathology is critical in for the diagnosis of AIP. And to the current date, what we know is a Francine needle is best. Steroid is still the backbone. Biliary stenting perhaps can help in this condition when the patient has biliary obstruction. Be very careful if you want to diagnose someone with IgG4 sclerosing cholangitis alone, without anything else, without AIP, without IgG4 related disease, because cancer is very highly likely. So I can tell you that there are a lot of things that we don't know in this area. First, we are in the era that the cholangioscopic exam is very good in terms of quality. What we need is, what are the findings that could be suggestive of the autoimmune process? And would it be in good agreement among the expert endoscopists? And then the other randomized control trial that needs to be done is Francine versus the opposing bevel. If you recall that when they randomized only bevel design, but not the opposing bevel design. And the last one is, what is the role for the biliary stenting in a prospective trial when the patient is refractory to steroids? And I put a few stars here that all the studies from now on, I think that they have to use the same criteria, which is the ICDC. Otherwise, you cannot compare the studies in the future. Thank you so much.
Thank you so much, Dr. Toss. Now I would like to ask Dr. Lead if we can start taking a few questions from the chat and discussing them.
Yeah, certainly. Thank you. That was an absolutely spectacular set of talks there. I really enjoyed that personally. This is always a very interesting disease, and I think the first thing to say is it just shows how much, we used to call it autoimmune pancreatitis. It's IgG4 disease. This is a systemic disease that can pick out all kinds of different places, and whilst a lot of them seem to come to GI and gastroenterology, they can turn up all over. Now, there's been some really good questions coming through the chat. I've seen Nadeem and a few others answering as we go, but there's some clear themes there, and we'll pick up on a couple of these. Perhaps the first one should go to Toss is about actually tissue. So someone was asking about whether cytology is good enough, and I think they mean brush cytology from ERCP as well as FNA. I think that's a really good question. Not everywhere has EUS FNA or EUS FNB available. We personally use the opposing bevel needle, and that works very well for us, but we're very lucky we work in a sense where we have that. Not everywhere has that, so it'd be interesting to perhaps chat about that. And others were asking in a similar way about, can we just rely on the serology? Do we really need tissue? And I think you've summarized that very well, but I think it's just really worth reiterating the importance of where tissue comes in here. It'd be grateful if you could just summarize that for us.
You mean from me?
Yes, if you could, that'd be great.
Okay, sure. So what I would say is that up to the current data, I don't rely on serology alone. And then if I want to diagnose someone with IgG4 involvement of the pancreas or the bile duct, then I have to find some other reasons, like why this patient should have this diagnosis. Do they have the periodic thickening involvement? Do they have retroperitoneal fibrosis? Do they have any other organs involvement, let's say thyroid or the eye sockets, things like that? Then if they are very convincing data, then my next thing is I have to get the tissue. And the best tissue is actually like what we talk, the pancreas, that I would pick only fine needle biopsy for now. And then at the same time, I will get the sample from the ampullary part as well. If you recall that the idiopathic duct-centric pancreatitis do not require the diagnosis from the ampulla, but you won't know until you go in, until you get the biopsy. And what you don't want to do is bring the patient back for the second procedure because you don't have the answer yet. So I will review imaging first, try to find other organ involvement, get the pancreatic pathology, get the ampullary biopsy, and then go from there. That would be my approach.
Thank you. Dr. Hassan, it'd be great if you got any other thoughts you want to add into that, maybe?
So, so I think it's thank you everybody. Very interesting comments, talk, and I have a little bit maybe a different approach with regard to diagnosis. So first thing is I would go for the least invasive. Obviously, that is either a serology, imaging, and then also you can think about the ampullary biopsy as well. Pancreatic biopsy, FNA or FNB would be a last resort. I would do that. One thing I want to comment on is they have always talked about these thickening of the bile duct on EUS. EUS just, we have to remember that when we look at the bile duct, normally we should not see any wall layers. Okay, if you have a pancreas cancer, the portion of the bile duct in the pancreas cancer, you should not see any wall layers. Whenever you see a thickening of the bile duct wall, the number one thing is it's a cholangitis or some sort of malignancy. If it is a cholangitis, you would see 3 layers in there. I'm talking about, you don't have to do a probe, just a regular linear I'm talking about. Yeah. So you would see black, white, black. That means there is an edema of the bile duct wall. That's what you are seeing. So with cholangitis, especially infectious cholangitis or any other type of cholangitis, the only difference is in autoimmune or IgG4 related cholangitis, the bile duct wall thickening, you lose that distinction between the wall layers, but you have a bile duct wall thickening. So that indicates, okay, we're heading towards the right diagnosis of IgG4 related diseases. So this is what I wanted to comment on how the bile duct wall looks like. When you look at the pancreas itself, obviously it could be a focal involvement. So it does not have to be a whole pancreas. It can look like a mass in the head of the pancreas. But when you, if it's a IgG4 related or autoimmune, like autoimmune pancreatitis, type 1, 2, whatever that is, the bile duct, the pancreatic duct thickening could, pancreatic duct dilation could be present in uninvolved portion of the pancreatic parenchyma. But the involved portion of the pancreatic parenchyma will have a patent duct majority of the time, or at least a portion of a patent duct in there, even though it would be narrow. You may lose the duct to some extent somewhere in there, but if it looks like a 3 centimeter mass, maybe on both ends of the mass, you may see some lumen of that duct. So that gives you an idea. Other differentiating point is if it's a mass of like a pancreas, tumoral mass, cancer itself, that usually would lead to pancreatic atrophy, and you would not see the side branches. If it's a duct related to the inflammation or a chronic pancreatitis, autoimmune pancreatitis, you would see dilated side branches as well, like post-obstructive to inflammatory mass. Coming back to these are the EUS findings I wanted to mention about that. That's in my experience, that's what I see these changes in this autoimmune disease. With regard to doing biopsy of the pancreas, as I mentioned, we have to keep in mind it's a very, very delicate organ, and especially in the area which is a normal parenchyma. If you stick a needle there and if you hit a duct, you're going to cause a pancreatic enzyme leakage and you're going to cause the pancreatitis. So don't take it just like any other procedure, sticking a core needle into the pancreas. And also what happens with the type 2 is parenchyma could be normal. If you do a parenchyma biopsy without any side branch in that biopsy specimen, you may not have a diagnosis. It's going to be probably normal IgG4 levels in there. So you have to have some part of a side branch in that biopsy specimen to get a periductal IgG4 cells. So here you're still putting a patient at risk of pancreatitis. I know the studies have shown that probably it's a safe, but just keep in mind, be careful when you come to that point. Okay.
I agree. Any other comments from the panel? I mean, I think the thing I would emphasize here is these patients, you know, they come along with a mass or a biliary stricture, and the biggest, most important thing is, do they have cancer, yes or no? You need to know that first up. The ones where we've seen this go wrong is when a peripheral center has sent us someone saying, oh, we think we've got IgG4 disease, they've got pancreatic cancer. They've missed the diagnosis because they had a swollen pancreas on the CT. Well, that's what you expect sometimes in cancer. We need to be absolutely certain they don't have cancer, radically different disease. I think if we learn anything about this, rule out cancer, then you can get onto the complexities of IgG4 disease. Sorry.
I'll just add something over there. One thing which is very important is, of course, high index of suspicion, but also communication with your radiologist and with your pathologist. So if you have to tell the pathologist that this is what I'm suspecting, and if you can specifically look for IgG4, if you can do the immunostaining, because if you just take a sample and send it just for histology without giving any clinical history, you may be missing some of these diagnoses.
Absolutely. Romy, did you have something to add?
I wanted to ask Dr. Sandhu for his opinion. He actually answered.
Oh, great. So let's move on through some of the other questions. There's been some good chat about treatment. I always find this interesting. I mean, there's a group of patients, it seems to me, who they clearly present, we've made a definite diagnosis of IgG4 disease, but they're not particularly symptomatic. We talked about treatment or not treatment and what do you do there, or is a biliary stent on its own without steroids enough in some of these patients who've got minimally symptomatic jaundice? And Again, I think that's an interesting question. There's a bit of other chat about those people who've been given steroids. So if they have a course of steroids, it all settles. Do you leave them on a low tapered dose? And I think some of the data I've seen is there's differences between different parts of the world as how we do this. So particularly in East Asia, there's a big push to stay on steroids. In Western Europe, we haven't done that, but I think there's been better data come out to suggest that maybe we should have been doing. But I'd be interested in some chat about that. Any thoughts from the panel?
So I'll start on that. So one of the thing is with IgG4 is if you leave it untreated, there is a chance that it'll develop a complication, especially fibrosis. And the whole idea with the treatment is to prevent that, because fibrosis is irreversible. So once you get to that stage, and even with the pancreas, we know that chronic pancreatitis, you see all those changes where there are stone formation, and the risk of causing or developing pancreatic cancer, it's still dubious, because there's only one study which showed that there's no relation between IgG4 autoimmune pancreatitis and pancreatic cancer formation, but other studies have shown that there is some progression. So that's at least in my practice, I do start them on steroid, and then as a steroid sparing agent, I put them on Imuran. And generally for these patients, we do not need such high doses like we need for IBD treatment. So this is treatment like autoimmune hepatitis. So low doses, maybe like a 50 milligram Imuran long term. That's what I do.
Yeah, sounds good. Nadeem, any thoughts on that?
No, I agree. I think if I remember correctly, we have seen a paper recently study where they've looked at what level could you really not intervene and just start the patients on steroid. And if I'm not wrong, I think it was sort of around 5 or equivalent to ours, around 100 what we see in our practice. So if it's up to that, you can maybe just start on the steroids without putting a stent in. But I think if I may ask a question too, obviously I think to Dr. Hassan about in terms of role of cholangioscopy and the so tissue acquisition is a concern. Yes, obviously you have to rely on the serology and other clinical markers and avoid biopsying the pancreas. But if you can't really, I mean, in the IgG4 world, people are not very keen on the ampullary biopsies. There are some concerns, if I remember correctly. It's so I would like to hear what you have to say for this.
So I think Toss kind of mentioned about the cholangioscopy, showed some pictures in there, and really it's hard to even sometimes differentiate if between different type of cholangitis. The only thing what I have noticed is like if it is a cancer, you would see kind of more like a papillary projections on that with a neovascularization. In case of these IgG4 related disease, it usually does not give you a papillary projection. It's more like a smoother. You may see a vessels in there, but more like a smoother, and it would be a longer stricture. It won't be like a PSC stricture, which are the skip strictures, and it would be a little bit longer. So that is, I like cholangioscopy really. If I have to choose between a biopsy in pancreas and cholangioscopy guided biopsy, I would rather probably go with the cholangioscopy guided biopsy. So the same thing, morphologically, longer strictures may have a neovascularization, but usually probably won't have a papillary projections, just like which happens in usually cholangiocarcinoma, and that's what I would look for.
That's very interesting. We've not touched on this very much. We have looked at AB. We've got a reasonable cohort of IgG4 patients in Newcastle, and we've got quite a lot of them who present either directly to ophthalmology, ENT, or even just rheumatology. Rather than to us. I think 2/3 of them came to GI services, but a number of them actually went to more of the extra intestinal groups. And we found when we looked at it, we found some differences between them. IgG4 levels in the serum were a lot lower in those patients, a lot higher in those in the GI system, which maybe accounts for some of the lack of sensitivity of that as a serum marker. But also they often presented with more organ-threatening disease. If your eye is in trouble or you've got a perforating lesion in your palate, they tended to leap in very quickly with things like high dose immunosuppression and rituximab. What I tend to find, I was really interested in Dalbi's comment there about steroids. We do give steroids, of course, and we do give other treatments, but very commonly, just following these patients up, once the inflammation is settled, you're often left with this thin strip of not much of a pancreas left. And I don't know that steroids prevents that definitely from happening in everybody. It's almost like it burns through it and leaves this lack of a pancreas. And it's very common to find that they get exocrine insufficiency, but also endocrine disease along with that. And so they often do end up being quite complex patients with a need for enzyme replacement, a need for glucose control, and a number of other issues related to those things. And I think they're quite complex patients.
And this is the reason they need to be followed up on the long term to prevent, obviously, look for relapse, and also if they end up developing chronic pancreatitis, which obviously would need treatment.
Yeah. Now we've set up in our unit what's called an IgG4 related disease multidisciplinary team. So this involves radiology, pathology, gastrointestinal services, ophthalmology. I mean, they're coming out of the woodwork. Renal get a lot of them. They get people with funny lesions in the kidney. Suddenly we've got this multi-systemic group who get together to chat about them. And often we use it for, is this the right diagnosis? Clearly want to not miss cancer, clearly not want to miss things like lymphoma, which sometimes looks very similar, but also to discuss the best treatment. Now, I'm a gastroenterologist. I'm quite happy using steroids and azathioprine. I've never given anyone rituximab. It's not a drug that I use, so we send them to our rheumatologists who use things like this all the time. And they're therefore got all the setup, all the right ways of doing that. And I'm just interested in what it's like in other centres, how you manage these. What we've just described here, very often complex, multi-systemic disease patients.
So, I mean, we have a clinic where we have an immunologist and rheumatologist as part of the clinic. Right. So we do prescribe rituximab to our patients. It's on a 6-monthly basis. We do tend to check their IgG4 level. I don't know if that's evidence-based or not. But if they are sort of deemed at a higher risk of relapse to begin with, and as I mentioned, if they are consistently either type 2 or they've got a really high IgG4 levels to begin with, then those are the ones we would really go for rituximab, because if as I said, there's no randomized control trial supporting azathioprine or 6-mercaptopurine. And when you look at the mycophenolate or cyclophosphamide, all the trials have been done with the steroid, so there's not been assessed their efficacy alone. Therefore, if they're at high risk of relapse or multisystem disease, then we go for rituximab given every 6 months, and we tend to sort of check their IgG4 levels. There are very few who have sort of come off it, but majority of those, I mean, we haven't got about a cohort of 16 patients over the last sort of 5 years or so. And those are the ones, so there are some who've not required any treatment, as I presented that young girl who've been under a follow-up for 2 years and has been really, really well. So that's our practice. But the advantage of having a rheumatologist and immunologist in the clinic is obviously I feel relaxed in prescribing it.
Yes. Any other comments from anywhere else? Nadeem and I both work in the UK, obviously, so we have a certain NHS setup, but I'm interested to know how this works in other parts of the world.
I think Dalbi can support me here. I'm really, like you guys, John and Nadeem, you guys can get, you have even a clinic together here. Getting 2 doctors together in the United States is a kind of a task. So usually have these multidisciplinary meetings, but usually those are for cancers. And John, I agree with you. I can give a 6-MP, I can give a steroids, but for rituximab, I have to get help from a rheumatologist. So usually it's very easy for us to get a consultation, but getting 3 doctors together in one place, good luck with that in the United States. So I think we usually rely more on individual consultations. I don't know. Is there anybody to support me on that?
No, I absolutely support you on that, Dr. Hassan, because just as you mentioned, most of the multidisciplinary meetings are for cancer-related diseases. And for anything which is non-cancer, just gathering 2 or 3 doctors, it's very, very difficult. So most of the time we end up talking to everyone on a one-to-one basis. And I had maybe 2 patients that I remember who would not go off steroids, so I send them for rituximab. I don't give that again. I send them to my rheumatology colleagues, and they take care of those patients. One more thing, I mean, in my opinion, with the type 2, they do not have any chances of relapse. Do you follow them long term? Because I had one patient and I stopped following after some time because, so I probably would want to hear everybody's opinion on this.
That's a really good question. I think the proportions, I'd be interested to know what the rest of the panel and speakers say, is that actually the vast majority of patients are type 1s. They're the ones we tend to see the most of by and large. I think out of the cohort that we have maybe 1 or 2 type 2s. I wonder if they go, under the radar because they present with an event, it gets better, and they go away and they don't come back saying, well, I think I may have had something. That's not a way that patients present to us. So I really haven't seen very many of them at all. And maybe they do relapse and we don't know because we don't fully understand that group. And I suspect that's part of it. But I really have very little experience of the type 2s. Most of the ones we see are type 1s. Be interested in others' thoughts.
Yes, I mean, to be honest, I've only just have one. And that's quite in the last 2 years. So I'm still following it up. I don't know whether I'll continue to follow up or not, but.
Yeah. I think it's out of our own curiosity at that point, isn't it? It's Romy or Dr. Hassan, any of the thoughts on?
Yeah, I don't do clinics, so I don't follow patients. I am basically endoscopist. No, I honestly don't have experience with that type 2.
Okay, I think we'll probably, close to concluding the session. And I know Dr. Hassan had got a 13-month-old waiting on the table with situs inversus who needs an ERCP. So he does all these amazing things. Anyways,
it's
over
not
to,
just that, it's also post-liver transplant and hepatogenostomy. So I got to go find the hepatogenostomy. Thank you so much, guys.
Thank you so much.
Thank you so much.
Thank you.
Thank you.
Thank you.
I would like to thank everyone who attended today, and especially I would like to thank again PSSLD and Dr. Abbas and all our amazing panelists and speaker. Thank you today for this amazing presentation.
Thank you very much. So I just want to pay my thanks to all of you. It was an excellent talk and we learned a lot from all of you. Excellent presentation by Kashia, Nadeem and Tosh. And superb comments by Khalid Hassan. It's always a pleasure to listen to Khalid Hassan. He makes things very simplified. I heard his lecture about EUS accessories last Sunday. Excellent talks always. And good comments by John Leeds. Thank you, John, again, and Dr. Sandhu. And wonderful moderation, Romy. Thank you very much. Okay, thanks again.
Thank you.
Thank you, Dr. Abbas.
Thanks,
everyone.
Thank you, Dr. Abbas.